we remember the dens, which is part of the C2, which is the axis. Okay. So again, we'll come back to the distance. The distance here is small, usually between the C2 anterior arch of atlas. Now, if it's widened like this, okay, we have seen the rheumatoid arthritis can affect the ligament, okay. You can have it enlarged, but you can have it also in trauma, okay. So when you see something like this, you have to suspect the trauma, if it's in the context of trauma, of course. So this is widening of the predental space. So this is the dens, predental space, or distance between anterior arch of atlas and dens, as you wish. So odontoid fractures should be suspected if there is anterior tilt of the odontoid. So we have seen the odontoid process, it looks straight. So if you have a tilt anteriorly, posteriorly, you should suspect a fracture. The lucent fracture line might be visible, usually better seen on CT, of course. Sometimes the only sign of the fracture might be the prevertebral soft tissue. This is why I told you have to see the soft tissue, and you can see the distance, how much is it. And the odontoid fractures are generally divided into 3 parts, okay? Type 1, which occurs at the tip of the odontoid process, which is usually stable. It's only the tip of the odontoid. Type 2, which involve the junction of the odontoid process and the vertebral body. So the dens at the junction of the dens with the vertebral body of C2. Type 3, through the superior aspect of C2. So this is extending to involve the body of C2, okay, at the base of the odontoid. So these two, type 2 and 3, usually are unstable fracture. And they can be associated commonly with anterior or lateral displacement. For example, here you can see this is taking the base, okay, of the dens, okay. This is type 2, and this is usually considered unstable. You see the CT scan is showing elements that probably you don't see it very clearly in the X-rays, okay. You can see that there is slight posterior displacement of this fragment, right? So we can see more elements, okay. You can see the fracture line much better. You can see the displacement of the vertebral bodies, okay. But X-rays, it's very simple, very fast, can give you an immediate answer in the ER, and it's very helpful. And you can see the soft tissue. Of course, here it's not well clear, but we can see also the soft tissue. So type 1, just the dens. Type 2, it's reaching to the base. Type 3, which is taking part of C2 vertebral body, okay? So 1 stable, 2 and 3 unstable. So this is type 3, okay? This is taking the body of C2, okay? You can see that this patient has severe arthropathy, cervical spondylosis, degeneration, and you can see the ossification along the anterior longitudinal ligament, posteriorly as well as the OPLL, ossification, posterior longitudinal ligament. So it's like a rigid spine, and you can imagine there is a small flexion here, then you have this fracture that happens. Chance fracture, we have seen it's a severe flexion injury, but this is not in the cervical. Usually this chance fracture happens in the lower thoracic, okay, at the thoracolumbar junction, okay, and you have a severe injury, you have disruption posteriorly of the ligaments, and then you have compression, and you can have a horizontal fracture going through the pedicle, okay. This is not a simple X-ray, okay? It's just to illustrate the fracture going through the pedicle. We don't do this anymore. These are called tomographies, okay? It's like a specific coronal cut level of the pedicle. But nowadays, the patient, we send them to CT to see better the fracture line. When you have a fracture line going through the pedicle with this compression, so it's a severe hyperflexion injury with pedicular fracture horizontal, you can suspect a chance fracture. This is how it looks like in the CT. You can see the horizontal line going through the pedicle, and it actually there is a compression associated. You can see, for example, this vertebral line. This one is anterior wedging, slight deformity here, and this there is a horizontal line actually going anteriorly. So it is hyperflexion, and there is a ligamental injury associated. So these are considered as unstable. Instability is common. Okay, chance fractures are hyperflexion injuries in which there is distraction of the posterior elements. So the posterior elements are widened, and impaction of the anterior components of the spine. Okay, so it's a severe hyperflexion injury with pedicular fracture going through the pedicles. Now, vertical compression or burst fracture, and we're going to take a specific example in the cervical, which is at the C1 level. The burst fracture, which is the intervertebral disc, is driven into the vertebral body. You can see that if the compression of the vertebral body, the intervertebral disc will be severely compressed and going through vertebral bodies, either superior or inferior, and the fracture fragments may impinge on the cord. Okay, so you have a burst fracture. So the different parts of the vertebral body that has fractured might go also posteriorly into the spinal canal and compressing the cord. So this is unstable fracture. Although it might be affecting, well, it is affecting two columns, okay, the anterior and posterior and middle. So if it's affecting the posterior third, okay, the anterior third, anterior 2/3 and posterior 1/3 of vertebral body. So these are two columns, okay. Now we'll see the Jefferson fracture, which is specific. This is the C1. So it has a name, the Jefferson fracture. What is it? It's similar. It's a compression fracture of the bony ring, but this is affecting a specific vertebra, which is C1. It doesn't have a body. As I told you, it has two arches, anterior and posterior, and lateral masses, characterized by lateral masses splitting and transverse ligament tear. So the lateral masses are splitting laterally. Mechanism, it's an axial blow to the vertex, diving injury. So you can have a diving injury if with a flexion. If you have a flexion, you can have a teardrop. But if it's a little bit more straight, you can have a Jefferson fracture. So what is that? What do you see in X-ray view in the AP? And here you have to do the open mouth. It would be nice. If you're not, of course, then you'll do the CT. But what do we see? Displacement of the lateral masses. That's why I told you that positioning of the patient when you do X-rays is important in the lateral view and in the frontal view, because if you see lateral masses moving, it's a sign of a fracture. Okay, it's positioning is very important. So lateral masses, they move beyond the margins of the vertebral body of C2. A lateral displacement of more than 2 millimeter or unilateral displacement may be indicative of C1 fracture. CT, we have to do the CT to see really the location exact of the fracture and the displacement of the bony elements. It's highly unstable. So open mouth, again, this is a tomography. This is just for illustration. Open mouth might not show you as good as this one. It can actually, but in trauma patients, if they are not mobilized, we put collars. Well, sometimes it's very limited. But just to show you the example, so this is a facet, lateral mass articulation with this one, and you can see the displacement of this is the C2, this is C1. Okay, this is the lateral mass of C1. It's not articulating. Really, there is a displacement laterally of the lateral mass of C1, lateral to the lateral mass of C2. The same thing here. So both lateral masses has been displaced laterally. And this is the fracture. So you can see the disruption of the ring, the bony ring of C1, and the lateral masses are moving laterally. Okay, so it's a very nice, and the CT is showing it very clearly, but even this tomography is showing it. And if you were able to do an open mouth, then you can demonstrate this. This is a normal open mouth. Okay, just to see the anatomy again, we have seen it before. The dens is here. You can see how the normal articulation of the lateral mass of C2 with the C1. They articulate, and this is the articulation, and they are really covering each other exactly. You can see the movement here that is moved laterally. Okay, again, midline, and the distance should be the same. Here it's enlarged, okay, but here it looks like symmetric, but both of them has moved. Sometimes you can have one lateral mass moved and the other one not much, not necessarily symmetric displacement, okay? So disruption of the bony ring and displaced lateral masses, okay? So this is the bony ring has been disrupted, and this is the transverse ligament, okay? This is another one. This is it can be a very strong ligament holding the two lateral masses together. So if it's still intact, it will not be a complete displacement laterally, okay? Usually when you have a significant displacement, usually this transverse ligament is disrupted, okay? Here you have also displacement, okay? This is the lateral mass. You can see, as I told you, sometimes the open mouth, you don't see very clearly as tomography. But even this, you can suspect it, and you can send the patient to CT for better evaluation, what's happening. You can see the projection of the uh, elements of the tooth. The tooth are here covering a little bit part of the facet, but you can see that the articulation is not really well respected. Burst, we have seen that this is a compression without rotation, okay? It's a compression fracture, but the problem is that you can have displacement of part of the body, vertebral body, into the spinal canal, and then in this case it can be unstable. If it's only affecting anterior, let's say the only one anterior colon, uh, then it's usually stable, but can affect, imagine that it's affecting only the middle colon, then even if it's a single colon, it is unstable if it's affecting and going into the spinal canal. But this is, you can see it's, I don't know if you can call it, and this is really unstable, okay? You can see that it's reaching here. There is an extension of the vertebral body into the spinal canal. You can see it here. And this is the burst fracture, and there is a slight posterior displacement. Don't see this bony element very clearly as in CT scan. Here you can see the alignment is disrupted. Okay, we don't have, you see, if you can draw a line, we don't have the same. You can see decrease in height. You can see tilting of the vertebral body here. We lost the normal alignment of the posterior vertebral line and the anterior vertebral line. There might be a hematoma associated here in this distance. CT scan is showing the extension of retropulsion of the vertebral body into the spinal canal. Another view of a burst fracture, okay? So you can see also here an extension, retropulsion vertebral body into the spinal canal. And this is the reformats in the sagittal view. You can see this retropulsion. So CT shows you more details actually than X-ray. So X-ray is like a primary investigation that you can do it very fast, and CT, it's really investigation of choice, because this is what we call a bone window, but we can have a soft tissue window. You can see then also all organs. Okay, when you have a polytrauma unconscious patient, uh, you cannot examine the patient because he's unconscious. If that's really difficult, you need a full investigation. So we can see the internal organs like kidneys, liver, spleen, pancreas, stomach, retroperitoneal part of the body. And you can see the bony elements as well at the same time. It can show you, and you can imagine you have a lot of images, so it takes a little bit of time to look at all of these. The 3D reconstruction, we have seen it, a similar part, and the narrowing of the spinal canal. Another specific injury in the craniocervical region, which is the hangman fracture. Okay, hangman fracture. It's a hyperextension. So Jefferson, it's a compression, and you have disruption of the bony ring, and lateral masses are displaced laterally. The hangman fracture, it's a hyperextension, and example, of course, it came from the hanging process, okay? But what's happening in the hanging process? The chin, on an example, the chin hits the dashboard. So you can imagine that the chin is hitting the dashboard. You have a hyper extension if you have a road traffic accident, okay? It's like the same process that happens when you're hanging a person. So what will happen? You have a hyperflexion, okay? When you have a hyperflexion, then you have a fracture in this part posteriorly. So you have a prevertebral soft, because ALL is also disrupted, prevertebral soft tissue swelling. You have avulsion of the anterior inferior cornel of C2 here. This one is disrupted with rupture of the ALL, okay? And you have anterior dislocation of C2. You can see the alignment, okay? Really not well. You can see that slight anterior displacement of C2 over C3, okay? Anterior dislocation of C2. You have bilateral C2 pars interarticularis fracture. So the pars interarticularis, it's in this part, the junction, which is just behind the vertebral body. Both laminas and the posterior element of the arch here are separated from this actually. So this is more just showing a clear separation with the hematoma. So you have a disruption of ligaments anterior, posterior, you have a hematoma, and you can imagine that you have a severe cord injury. It's highly unstable and associated usually with cord injury. So if you review a little bit the different types, let's say the most important here, the unstable. We have seen the Jefferson fracture, which is affecting C1, hangman fracture affecting C2, the flexion teardrop fracture. We saw the example in the cervical spine. We have seen the chance fracture as well, which is affecting the lower thoracic spine. Bilateral interfacet dislocation, when you have more than 50% of displacement of the vertebral body over the lower one. And you have anterior subluxation. That's all, they are associated with each other actually in this part. The others, these are stable, okay? Technically, sometimes the burst fracture, they're considered stable, but as I told you, when you have a posterior displacement of vertebral body, it's an element to consider unstable, okay? There is part of the bone going into the spinal canal, so this is considered as unstable. But you can imagine this is happening in the lumbar spine, for example, which there is no cord at this level, for example, at L3 or L2, if it's below the conus. So if there is a small extension of this vertebral body, it's not compressing anything because you have a lot of CSF and thecal sac is filled with fluid, okay? But you can imagine if it's in the thoracic or higher up and the cord is adjacent, then it might be considered unstable. But these are the important unstable. This is a lateral view, lateral fracture, and you can see fracture lines. So we have lateral radiograph of the spine with a magnification view and the sagittal and the T2 weighted images. But this is not a fracture actually. This is look at the bone marrow. The bone marrow constitution of the vertebral bodies here. This is a regular T2. We said that fluid is white, okay? Fluid is white, and we have something white here. And white in the bone, it's inflammatory changes, okay? It's when you have edema, this is inflammatory changes. You have water content, okay? When you have edema. So it can be traumatic. And when you have trauma, you can have a similar appearance. But the thing that makes it suspicious of infection here, of course, you have the context. You have, if there is a context, but for a radiological point of view, look at the disc spaces. This is a disc, this is a disc, and the discs here are black because there is no water. Okay, you have annulus fibrosis, and you have very minimal, like jelly content in the nucleus pulposus, but which is not really visible here. But look at this. This is the area of the disc. and here there is water content. So how can we have water content on the disc? Then you have inflammatory changes on the disc, okay? So here probably, of course, you have to take always the clinical contact, but this is discitis, or it's not only disc because it's affecting the vertebral bodies above and below. So this is spondylodiscitis or osteomyelitis, discitis, osteomyelitis, okay, association. Uh, and there is a compression of, you can see there is a bony element here. The patient maybe has some degeneration. There is an epidural extension. You see this? There is, because we see this in the sagittal. If you have seen this in the axial planes, there is probably around this inflammatory changes, you have a collection going around and extending posteriorly, and this is an epidural. You see this? This is an epidural collection, okay? This part. This is epidural extension. So it's compressing the cord here, and you have signal changes within the cord. This is we call myelomalacia, okay, which is edema in the cord, okay. It's just to show you that a little bit of different pathologies, not only trauma. It's not really. I just want to show you that what can MR show you. We can inject, of course, contrast, and we can see then enhancement in the disc space, okay? And you can see the limitation. This is the dural coverage. It will be enhancing, but this part will not be enhancing. X-ray, of course, cannot show the collection. Osteoporosis, I showed you this, the progression of osteoporosis, okay? We have seen an example. This is for metastasis or secondary deposits, okay? Sometimes you can have a cord compression, then this might require as an emergency surgery, or sometimes depends, sometimes they go to radiation therapy, depends on the pathology, okay? But you can see here this vertebral body, how it's affected. The bone marrow is infiltrated, and you can see it's in contact with the cord, compressing a little bit the cord, but there is a little bit still of fluid maybe, so it's not a severe compression, and we don't have signal changes in the cord, okay? We don't have myelomalacia yet. This is a simple X-ray just to see how important, when you, as I told you, to see the central elements. We have the spinous processes, and then you have to see the pedicles, okay? You can see them here, these pedicles, okay? And you go here, and these are the pedicles, okay? And you don't have a pedicle here. You see this? Here you lost the pedicle. So it's really important to be systematic when you see X-rays. The lateral view, you have to see the different lines, and the frontal view, you have to see always the spinous processes and the pedicles, and it should be symmetric, okay? So this is how it's important, and you can see involvement of the pedicle, and you can see a reduction in height of this vertebral body. Send the patient to CT scan, and then you have a big metastasis in this vertebral body, which is extending to the spinal canal and causing cord compression. Then in this case, MRI is the best element to see how is the cord compressed, okay? And of course, clinically is very important. You tell me that we want urgent MRI for cord compression. It's not enough. It's not enough. You have to tell me which level you're suspecting. When you have a cord compression, you have a level. You should know your different sensory dermatomes, which is the level. Are we talking about T12? Are we talking about T6? Because the level, then that means that we have to do and cover this area, okay? Which area are we going to cover? The whole spine? If you're going to do the whole spine in MRI, that means that these are 3 different exams: cervical, thoracic, and lumbar. So these are 3 different acquisitions. So the patient will stay in MRI for almost more than 1 hour or 1 hour. Okay, so it's a long exam. That's why we need to dedicate the level. Sometimes we can do like screening, but it's not ideal. The patient is coming to MRI. We should have a good study, actually. It should be dedicated, and there should be good communication in the request. Bone scan, it's very nice actually to see the whole spine. So this is whole spine MRI, and you can see, for example, you can see the skull, you can see the whole axial and appendicular skeletal part, frontal view, the posterior view, anterior and posterior view. And if you have metastasis, you can see that the tracer uptake, or it's holding in some areas. There is normal uptake. This is a urinary bladder, okay? This is not, but you can see, for example, here the different tracer uptakes in the ribs, in the vertebral bodies, and in the shoulder, and these are all secondary deposits, okay? So the bone scan is very nice to have like a skeletal, global skeletal survey for secondary deposits, and also good for follow-up as well. Okay, this is bone. Okay, bone scan. Another element which is not really related to acute trauma, but sometimes it might be repetitive microtrauma or congenital spondylolisthesis. Okay, it's the pars interarticularis, which is sometimes they're not few, yani you have a disruption of this posterior elements, and the anterior part of the, let's say the vertebral body, it slips. It slips because there is nothing holding it posteriorly. So when both sides, right and left, are disrupted, you can have slipping of the anterior part, which is the vertebral body. So L5 now slipping over S1, and this is not like an acute trauma. Usually it's either repetitive micro trauma, or you can see it, we don't know really, even sometimes in adolescents sometimes. But what's happening here, when this moves anteriorly, you have to see how important is the displacement. The problem is that when it goes anterior, it might compress the nerve root that it's going out, okay? So this is spondylolisthesis. Spondylolisthesis is the disruption of the pars interarticularis. The spondylolysis, sorry. The spondylolisthesis is the displacement, okay? So we say anterolisthesis or posterolisthesis, or but globally spondylolisthesis, and we can grade it. Grade 1 is like 25%, 2 between 25 and 50, and 3. And you can grade it in 4 if you want, like every 25%, okay? But this is probably like grade 2, 3. It's almost reaching 50%, or maybe less. But this is spondylolisthesis. This is another X-ray just showing secondary deposits. Okay, prostate. You know that prostate cancer, very common in elderly. Okay, very common. Our population is not as old as in European and Western countries, so we don't see it as common as outside. But for example, this is how it looks like. Again, you can see the alignment, the frontal view, and the pedicles, and there's something strange about the content of the vertebral body. You see, this one is white, right? So it gives you immediate appearance. You have sclerotic lesions, sclerosis of L4, okay? The bone scan, there you can see there is tracer uptake in L4. This is metastasis of L4. It's sclerotic or blastic, so it's a sclerotic. Usually, very commonly, state metastases are sclerotic. It can be mixed, but very commonly sclerotic. Okay, so this is prostate cancer. Okay, you can have the same here. We have, unfortunately, we have breast cancer a lot. We can see mixed sclerotic and lytic as well. So this is just showing scoliosis. When you have a deformity of the spine and you have a rotation, okay, of the spine like this, convexity. So this is left convex lumbar scoliosis, okay, and surgeons, orthopedic surgeons, they go inside and they try to align it a little bit better. So they put transpedicular screws. So we go through the pedicles and put screws, and they open. Sometimes if there is a spinal stenosis, if you have degeneration, they open the lamina. You can see, for example, here you have a spinous process. Here you don't. What happened is that the surgeon here they cut off the posterior element here, the lamina and the spinous process at this level and this level, okay? And he fixed it very high from this level up to L5, okay? To give some stability and to release the compression of the cord. So, so as I told you, it's not simple. Sometimes it's not one pathology. It's not a simple scoliosis associated with the degeneration, with this disease, compression of the nerve roots, compression of the thecal sac. You can have spinal stenosis. So they're releasing also the thecal sac and releasing the spinal stenosis in addition to the improving the alignment of the spine. Okay, I guess that's it. And this is, you can see it in children as well. And in this case, you don't have degenerative changes, but it can be an extensive correction, you know. But we do this actually. The orthopedic surgeons, they do them. And you need, yeah, you need sometimes specialized orthopedic in the spine to do it. I think this is the last. Do you have any questions, anything specific that you want to ask?
دكتور
Yes? Yes, please.
المحاضرة هذه معانا في الثيري، وأغلب المحاضرة نوعا ما سلايدات راديولوجي، فكيف ممكن
اي
تكون معانا في
كيف كنت تكون ايش؟
أنا أقصد إنه أغلب السلايدات صور يعني، والمحاضرة معانا في الثيري، فممكن كيف ممكن نساعد يعني بدون.
Well, you have seen the stable fractures and the unstable fracture. We have seen few of the unstable fractures. You should know them, right? You should know what makes the stability of the spine. You can show the disruption. You have seen the dents, right? Yeah, if he part of it that you should important information to know, and the different modalities that you have seen, the CT, MR, X-ray, the basics you should know. And what is having X-ray, what does not have X-ray beam, you know. What is fast, what patient unconscious, ايش حتسووا له, contraindications, certain MRIs for patient in trauma. يعني there is a lot of theory inside. Anything else?
دكتور أنا عندي
Any
سؤال.
Yes, please. Go ahead.
لو الانتيرير كولوم في injury مثلا fracture والposterior
Yes.
column كمان نفس الشيء بس الميدل column is intact، هل هذه أعتبرها stable ولا unstable؟
Unstable. Yeah, when you have involvement of two columns, is unstable. This is
حتى لو
simple. The
posterior
problem is that
ligaments
when you, but you cannot have injury of the posterior and anterior without instability. So what is the problem is that when you have a single column involvement, which is the anterior column, بس هنا this is a problem, and you have a part of the bone is going posteriorly, which without disruption of the ligament. Okay, so this is a single column involvement like the burst fracture. Okay, but يعني I think as I told you احنا يعني there are things to consider if you have a extension into the spinal canal. Where is it going? Is it compressing the cord or not?